Okay, there we go. All right. Hopefully people will sign on.
Good afternoon, everyone. So thank you for those who have already signed in. We are going to give people a few minutes to go ahead and sign into the webinar, and then we will get started momentarily. So thank you so much for everyone who has already joined in. All right, we're going to give people about one more minute, and to be respectful of everyone else's time, we'll go ahead and get started. So thank you all for your patience. All right, well, thank you all. We will go ahead and get started. So first of all, good afternoon to everyone who is on the call. My name is Dr. Damika Walker, and I am the chair of ImmunizeDC. It is indeed my privilege to be able to welcome you all to today's webinar entitled Making Meningitis Vaccination a Priority. So I definitely appreciate you all for taking time out of your busy schedules to join us for today's webinar on this pressing topic. We're all aware of the coalition's mission, which is having a healthy and informed Washington, D.C. community fully protected from vaccine-preventable diseases across the lifespan. And that is still our primary focus amid the COVID-19 pandemic. We all know that there has been a marked decrease in vaccination rates among children and adolescents during the pandemic. So we as a coalition decided to host this webinar and other opportunities to ensure that our partners are informed and equipped with the tools that are necessary to educate the community on the importance of catching up on those scheduled vaccinations. So we hope to continue to host these webinars on topics that are of interest to you in regards to your places of practice. So I do welcome your topic suggestions for future sessions. There will be a short webinar, a post-webinar evaluation that'll pop up right at the end of this session. So I do ask that you use that platform in order to provide feedback as to other topics that will be of interest to you. We are so very appreciative of your support, and we do value your feedback to help enhance the work that we are doing as a coalition. So again, we're so excited about today's webinar. We're very excited about the speakers that we have with us today. So without further ado, we're actually going to begin with the first session, which is Why Vaccinate? Personal stories from the Meningitis B Action Project. So we have two speakers that will be with us today. First, we have Ms. Alicia Stillman. She is the executive director of the Emily Stillman Foundation. She was named the foundation after her daughter, Emily, who was taken at the age of 19 by meningitis B in 2013. The foundation's work is to eradicate meningitis through education and action-focused initiatives. For the last 8 years, Ms. Stillman has been a leading advocate for meningitis vaccination in the United States, lecturing at academic, healthcare, and government institutions across the country. Her most recent initiative, which is the Meningitis B Action Project, currently provides educational materials and other learning platforms for thousands of US-based universities, and doctors' offices. In addition to running her foundation, Ms. Stillman is the Chief Executive Officer for a multi-state law firm based in Michigan. She holds a bachelor's degree from Arizona State University, a master's of business administration from Wayne State University, and a master of public health from the George Washington University School of Public Health here in Washington, D.C. We also have with us today Ms. Patti Wukovits, who is a registered nurse and executive director of the Kimberly Kofi Foundation. After losing her 17-year-old daughter, Kimberly, to meningitis B in 2012, Ms. Wukovits formed the foundation in her daughter's name to improve awareness of meningococcal disease and the vaccines available to help prevent it. As a prominent advocate of meningitis prevention, she has shared her story with thousands of healthcare providers, policymakers, school administrators, and students around the world, and played a critical role in the passing of New York State's meningococcal disease vaccination law in 2016. Ms. Wukovits currently serves as the Policy and Advocacy Committee of the New York State Public Health Association, and her foundation partnered with the Emily Stillman Foundation in 2017 in order to launch the Meningitis B Action Project, which is a nationwide disease awareness and advocacy initiative. Ms. Wukovits holds a Bachelor of Science degree in nursing from Chamberlain University. So we are very privileged to have both of these wonderful women with us today in order to discuss meningococcal disease and how it really does impact the community. So at this time, I will pass it over to them to give their presentation. Thank you.
Hi, and welcome. And thank you so much for inviting us to present our stories and present the Meningitis B Action Project. We're going to talk today about why vaccinate. We're going to share our personal stories and give reasons why we feel that the MenB vaccination is so important. Next slide. So this is my daughter, Emily. Emily was my middle daughter. And Emily, you can see that face when she would smile not just with her mouth turning up, into a smile. Her eyes lit up. She smiled with her whole face. She was 19 years old, and she was a sophomore at a small liberal arts college here in Michigan. She was a double major because she wanted to be on Saturday Night Live. And she always loved being on the stage. Comedy was her specialty. But her dad and I told her, you better have a plan B. So that was psychology. So she was a double major. And Emily lit up a room. Emily was vivacious and her smile was contagious and everybody wanted to be around her. One night in February, it was actually the very end of January of 2013, Emily called me and she said, Mom, I have a headache. And I thought that she was probably coming down with the flu. And she said, I don't think I'm coming down with the flu. She says, you know how I get when I get overtired? She says, I get that achy feeling in my body and my head hurts. She says, that's how I feel. I had a couple big tests today, but I was up all night last night. But don't worry, Mommy. She says, I did really good on my tests. So I suggested she take Motrin and she called me in the morning and we would see how she felt. That conversation I have replayed in my head for 8.5 years. But when I replay it, I say, oh my God, you have a headache. I'm coming up. But that isn't what I did. I said, take Motrin. And she went to sleep. It was about 10 o'clock. The next morning, I was called by the university and also the hospital. And I was told to get there right away that my daughter had bacterial meningitis. I remember saying, there's no way. She can't have bacterial meningitis. My daughter was vaccinated for bacterial meningitis. And I had no background in health. My background was in accounting, business, and I had no knowledge of bacterial meningitis, except I knew she had been vaccinated. Her year was the year that the ACIP recommendation changed to include the booster dose of the MenACWY. So I remembered that very clearly. And in those days, nobody said the MenACWY vaccine and then a MenB vaccine. That's all they said is the meningitis shot. So I drove to the hospital about 2.5 hours away. And I remember calling the pediatrician along the way and saying, just refresh my memory. Emily did have the meningitis shot, right? And they said, yep, she did. And still nobody said anything about meningitis B. When I got to the hospital, they asked me if I wanted them to call clergy. That's when I think I began to really think, oh my God, this might be really serious, because the whole way to the hospital, I kept calling back the nurse's station and say, I know she doesn't have bacterial meningitis. Double check the results, because I don't want something that's serious or important to go untreated because you think she has bacterial meningitis, because she can't. They just get up here and we'll talk about it. When I got there, they were preparing her for a craniotomy, because they said that the swelling in her brain was so severe that if she were to survive, they wanted to reduce the intensity of the brain damage that would be there. She did survive for this surgery, but she never regained consciousness. Most likely, Emily had been brain dead from the time she lost consciousness before I ever got to the hospital. I never got to see her eyes open again, looking at me, smiling. I never got to feel her arms around my neck. I never got to hear, Mommy, I love you again. She was laying there when I got there, and she remained there for the next day and a half when they confirmed to me that my daughter was brain dead. when I said goodbye to my daughter with tubes coming out of all parts of her body, I remember promising her, go, be at peace. I'm going to figure this out. I couldn't imagine, how had I let her down? What had I not done that I was supposed to do? And I said, I will figure this out, and I will make sure that this doesn't happen in other families. And so for 8.5 years, that is what I have done every single day. Patti?
Hi, thank you, Alicia. Thank you for having us, and thank you for the introductions. I am Patti Wukovits, Executive Director of the Kimberly Coffee Foundation and co-founder of the Meningitis B Action Project. I live in New York. You can probably hear my accent. I'm a registered nurse here, and my current role is as an oncology research nurse at Northwell Health here on Long Island, and I'm working on breast cancer clinical trials. My husband, John, and I have a blended family. We have 3 living children, my son, Chris, my stepson, John, and my stepdaughter, Jacqueline. And we also have my daughter, Kim, who is forever 17 and will always be a part of our family. And this is my daughter, Kim. So Kim was this adorable little baby. She had cute little freckles on her nose. She was just like, she was just a happy kid. She'd skip around all the time. She was just really funny. As she got older, you know, she was the life of the party. She was very vibrant. She was very full of life. She loved to sing. She had a great voice. She'd grab a mic anytime she could. If it was karaoke night, she was, you know, front and center. She'd grab, you know, a broomstick. She'd grab her hairbrush. She just wanted to sing. And she was really great. And she was also a great dancer too. She grew into a beautiful young woman who I was very proud of. And at the age of 17, Kim decided that she wanted to follow in my footsteps and become a nurse. And her dream was to actually become a pediatric nurse. She wanted to save children's lives. She had been accepted into a nursing program at a local college on Long Island, and she was looking forward to beginning that in 3 months. She was in her last week of high school. She was looking forward to prom. She was looking forward to graduation. She had a beautiful prom dress hanging on her closet door. I mean, she was set. She was ready to begin her life. When she was in her last week of high school, now this is in 2012, she was in her last week of high school. She called me while I was at work and she said, "Mommy, I have a temperature of 101. I just took some Motrin and I have body aches. Can you come home soon?" So I got home as soon as I could, called the pediatrician. By the time I got home, she was actually fine. The Motrin had kicked in, no temp. She was fine. But she insisted I call the pediatrician. So I did. And he said that it sounds like she, you know, perhaps has the flu. Check her out over the evening into the morning. And if she's not feeling well in the morning, touch base and you'll probably be bringing her in. Well, when we woke up the next morning, the situation was completely different. We woke up, she couldn't lift her head off the pillow. She said, "Mommy, there's something really wrong with me. I don't know what this is, but I'm really sick. Everything hurts me from my eyelashes down to my toes. And I also feel like my ankle is bleeding." So I looked back and at her ankle and I saw 3 tiny purple dots on one of her ankles. And I saw those tiny purple dots turn into larger purplish blotches. And I saw them literally travel up her leg, both of her legs. And she was going downhill very quickly. So I rushed her to the emergency room. When I got her to the emergency room, by the time I parked my car and got into the back, they knew what she had. They had already taken blood cultures. They had already had IV antibiotics running, and she was in isolation. And a ton of doctors converged on us, and they were asking Kimberly and I a whole bunch of questions. You know, "Kim, where were you? Who were you with? You know, contact tracing and all of this." I still had no idea what was going on until one of the doctors pulled me aside and she said that, "We suspect your daughter has bacterial meningitis, and we suspect that the bacteria has actually infected her blood." And I was like, "There's no way she can have bacterial meningitis. Like, what are you even telling me?" Kim had been vaccinated. I made sure both of my kids were vaccinated with the meningitis vaccine. And that's when I learned, when the doctor explained to me that that vaccine that Kim received at 11 and the booster at 16 only protected her against 4 of the 5 serogroups of meningococcal meningitis, and it didn't protect against serogroup B or meningitis B, which I had never heard of. I remember that moment so clearly because that moment was pivotal for me, because it literally changed my life. And unfortunately, it was the beginning of the end of Kim's life because things got bad so quickly. She was rushed up to the pediatric intensive care unit. Luckily, because she was only 17, she was able to go to the PICU. And she was septic. She was in multi-organ failure. And she was in septic shock. She went to cardiac arrest, and she was resuscitated and put on life support. And that was the last time I really didn't get to talk to Kim, except for I'm going to say the first day and a half. She was, asking me questions. She never did ask me, why am I here? And I never did tell her that you had bacterial meningitis. She kept saying, Mom, I want my phone. She wanted to text her friends because this was the last week of school and there was just so much going on. From there, Kim's limbs were turning black because she was losing oxygen to her extremities. And they did tell us that if she does survive, she would likely be a quadruple amputee. And she did have brain activity, so we had hope. However, as a few more days went on, she had impending brain herniation, and they told us to prepare for the worst. I had to get my son Christopher home from boot camp. He was in Oklahoma in basic training for the Army. So I had to get him home. We waited for Chris, and then we all said our goodbyes to Kim, and we took her off life support. And I buried Kim in that beautiful dress she had hanging in her room. I buried her in her prom dress just 2 days before her prom and graduation. So, I founded the Kimberly Coffee Foundation to educate the public and healthcare professionals about the risks and the symptoms of this disease, and I do this all in Kim's honor, because I just can't possibly let this happen to someone else, especially now that we have meningitis B vaccines. We have the tools now to help save lives. And I tell Kim's story of meningitis B because it's really important. Her story is relevant. She was just like the kid next door. And all of our kids' lives matter. All of our patients' lives matter. And by storytelling and by putting Kim's beautiful face and Emily's beautiful face to this very, very ugly disease is very impactful. And I believe that parents and healthcare professionals can relate even more. It's very important, storytelling is very important, but also we know the science and we know that vaccines work, we know they're safe, and we know that they save lives. And I just feel it's my duty to make sure that I tell other people Kim's story so that this tragedy does not happen to anyone else. Kim wanted to save lives as a pediatric nurse. She is doing it indirectly through me. I believe she is saving lives through the Kimberly Coffee Foundation, because I am her voice now. Next slide. So now we're going to talk a little bit about MenB and the vaccine. We have a video to show you. Meningitis B in 90 seconds.
Meningitis. You've probably heard of it. Maybe you've even had a meningitis vaccine. But did you know it takes 2 types of meningitis vaccines to help protect against one of the most common types of bacterial meningitis called meningococcal disease? Few people do. And why does it matter? Because meningococcal disease is pretty easy to spread. Early symptoms can often be mistaken for the flu. It is more common among 16 to 23-year-olds. And the really scary part? It can kill in a matter of hours, or cause permanent complications like brain damage, hearing loss, learning disabilities, or limb amputations. So what can you do to protect yourself? Meningococcal disease is mainly caused by 5 types of meningococcal bacteria, A, B, C, W, Y. That is why you need 2 types of meningitis vaccines, MenACWY and MenB. Few people have received the MenB vaccine. Why? It just became available in the US in 2014, and few people know about it. Ask your doctor today about the Meningitis B vaccine. Tell your friends and family to do the same. This message is brought to you by the Meningitis B Action Project, an initiative by 2 moms who lost their young daughters to meningitis B. Get to know their stories and how you can help at meningitisbactionproject.org. Meningitis. You've probably heard of it.
So a little bit about meningitis B. We won't go into this deeply at all because we know we have the medical experts on this webinar as well. So about meningitis B, meningococcal meningitis is the most common form of bacterial meningitis in adolescents and young adults, and it's caused mainly by 5 types of meningococcal bacteria, A, B, C, W, and Y. The bacteria can cause a bloodstream infection, meningococcemia, that can lead to sepsis. That was what happened with Kimberly. The bacteria can cause meningitis, an infection and inflammation of the membranes that surround the brain and spinal cord, and that's unfortunately what happened to Emily. So it takes 2 meningococcal meningitis vaccines to be fully vaccinated against meningococcal meningitis. The MenACWY vaccine, which more have received, with the first dose at 11 to 12 and the second dose at 16. The MenB vaccine, unfortunately, few have received. The first dose is given at 16 to 23, and the second dose is from 1 to 6 months, or after 1 to 6 months after the first dose, and that's dependent on the brand. The MenB vaccine can be given, the first dose can be given at the same visit as the MenACWY vaccine booster dose. So in Washington, D.C., the MenACWY vaccine is required for ages 11 and up, and in those enrolled in grades 6 to 12. And there are several colleges and universities that require it. Now remember, that's for the MenACWY vaccine. Currently, we know of no colleges or universities in Washington, D.C. that require or recommend the MenB vaccine. And we'd like to hear from you if you do know of any other schools, that do actually require the vaccine for MenB. Alicia.
So what are the key factors affecting the vaccination rates for MenB in the United States? First of all, the ACIP guidelines affects the rates very significantly. The ACIP guidelines are that the CDC says that 11 to 12-year-olds should receive the MenACWY vaccine at 16 to 20, at 11, I'm sorry, and then again at 16 to 23. Whereas the MenB vaccine, they may receive. The difference between should and may are huge. And why that difference is when originally reviewed, and it has been subsequently reviewed, the duration of protection is not completely given. The effects on carriage is not conclusive. The effects of herd immunity are not conclusive. We also know that there are multiple strains of serogroup B, and we're not sure which ones are prevalent in the outbreaks that on college campuses. And so we're not sure if it's going to protect against all strains. They also say cost. There is a low incidence of disease, and there's a high cost of routine vaccination. There is inconsistent understanding of the ACIP recommendation among providers. We did a questionnaire survey where we sent out to doctors and medical groups all over the country. And we asked, what do you see as the difference between the ACIP recommendations between the MenACWY vaccine and the MenB vaccine? The correct response is that MenACWY is routinely recommended, but MenB is subject to a shared clinical decision-making. Many medical practitioners don't understand the meaning of a shared clinical decision-making. As a parent, they can't participate in a shared clinical decision unless they know that there is a decision to be made. And nearly 50% of providers are not aware of the recommendation, and they're not aware of the decision to be made. Next slide. Many physicians are not doing their job appropriately. They're not talking to their parents about the MenB vaccine. In a study that was published in Pediatrics in August of 2018, 900 doctors were surveyed. 49% of the pediatricians and 69% of family physicians did not discuss the MenB vaccine. Remember, this is a pivotal age where many of the young patients, adolescents and young adults, are transitioning from a pediatrics practice to a family medicine practice. And so that's a really important statistic. Next slide. The other reason that a lot of people are not getting the vaccine is because there is a lack of school or college requirements. Whereas many colleges are requiring the MenACWY vaccine, they're not even necessarily mentioning the MenB vaccine, so parents aren't aware that there's a difference, or they're requiring one and not the other, so the parents think one is not important as the other. On the Meningitis B Action Project website, we keep track of the colleges that are currently requiring it. Our hope is this year, as many colleges are going to be mandating the COVID vaccine, that this is an easy one to slip in as well. So far, we haven't seen that happen, but this is a wonderful interactive tool on our website, and I invite you all to go in and participate in this. And if you hear of any schools that we don't have, please let us know. The college immunization forms and websites rarely call out meningitis B. And there's a few examples here, and it's really, really important. I mean, like, look at the Howard University. Meningococcal vaccination is required for all first time in college and or will live in residential halls. Booster should be on or after the 16th birthday. It doesn't even differentiate between MenACWY and MenB. Same thing really with the others. And so parents don't even know. They're in the same position Patti and I were almost 9 years ago, thinking our children were protected. But now there's the tools to protect them, and we're not even educating the parents enough for them to have the tools to do it. So the care-seeking behavior barriers are really important. On a provider level, they're not always following as closely by the pediatricians. They're not always followed. You know, the patients are going a lot less often. They're only going when there's something wrong, as opposed to yearly or timely for checkups. There's a transition between the pediatrician and the family practitioner's office, and there's poor access to childhood immunization records. And many times the patient and the parent don't even remember what vaccines they've had. On a patient level, it can be inconvenient. They're afraid of needles and there's too many shots. And let's face it, you know, if a medical office, if they are there, and the medical office, even if we are lucky enough that they recommend it, but they don't carry it, and many do not, they send them someplace else for the vaccine. And at this age, this patient is not going in search of the protection. They are leaving the office happy they didn't get another shot, and they're not going in search to find who carries the MenB vaccine. 80% of the parents don't know that there is a MenB vaccine. That's huge. 70% of all meningococcal cases in the United States are among 16 to 23-year-olds that are MenB. That's 70%. That is a staggering statistic, because we are routinely protecting 16 to 23-year-olds from ACW and Y, whereas 70% of the cases are MenB. 100% of college outbreaks since 2011 are caused by MenB. And 78% of the 16 to 18-year-olds have not yet received at least one dose of the MenB vaccine. Also, where we concentrate quite a bit on college students, because college students are 5 times more likely to get meningitis B than non-college students. I want to point out, Kimberly was not a college student. It can happen to anybody. Patti?
So the Meningitis B Action Project, it was created to help close the meningitis B awareness and vaccination gaps. Next slide. The Meningitis B Action Project is a joint initiative of the Kimberly Coffey Foundation and the Emily Stillman Foundation. And Alicia and I decided to join forces together so that we can amplify the message of both of our foundations, both of our organizations. And we educate all over the country about meningococcal meningitis through presentations, exhibits at medical conferences. And we just talk to everybody at colleges, high schools. We speak to policymakers on local, state, and national levels. And we've created educational materials, and I'll show you a few of those examples. Through the Meningitis B Action Project, we encourage healthcare providers to discuss the MenB vaccine with their patients, and we encourage them to give that vaccination at the same setting as the booster dose for the MenACWY vaccine at age 16. You know, the bottom line is that parents and young adults cannot act upon what they don't know. So we have to give them that information. We are empowering them with that information so that they can then have that conversation to talk to the healthcare provider should they not bring it up. This is a cute picture of Alicia and I at the Capitol a few years back. We had a resolution read declaring Meningitis B Awareness Day on April 24th of 2018. So we're always working to engage policymakers to facilitate broader access to the MenB vaccine. They need to know why it's so important. And by telling our stories and by educating them, we are giving them that information so that they can understand the importance. In New York State currently, for about the 5th year in a row, I have had a resolution introduced declaring each June as Meningitis B Awareness Month in New York State. Next slide. So our key message is this, and you saw this before, but we have tried to make what we feel is a very confusing message to deliver and a confusing message to receive, that there are 2 separate meningitis vaccines, because when we talk to patients, we talk to parents, and we tell them that, or we ask them, has your child been vaccinated with the MenB vaccine? They said, oh yeah, sure, they've gotten that. And then we say, well, we know what you're thinking. They most likely have only received one, and then we go on and we tell them the difference between the 2 vaccines, and then we see that light bulb go off and they go, oh, we didn't know there was a second vaccine. I'm going to go back to my pediatrician or my primary care, and I'm going to have that conversation. And I can't tell you how gratifying it is to us when we get the feedback that so many people have gone ahead and actually gotten vaccinated. So the message is, we make it as simple as we can, that more have received the MenACWY vaccine and very few have unfortunately received the MenB vaccine. And it's the fact that the 2 vaccines are necessary in order to be fully vaccinated against meningococcal meningitis. So through the Meningitis B Action Project, we invite you to go to our website, meningitisbactionproject.org. All of our educational resources, which are for students, healthcare professionals, and parents, are all downloadable. You can also reach out to us, and we'd be happy to provide you with information for your practice, for your school, for wherever it is that you feel you need more education on meningitis B. We'd be happy to work with you. We have brochures that are throughout the United States right now in thousands of doctors' offices and clinics. And we have posters that we hang on college campuses. We have tear-off reminder pads to be used in doctors' offices. We have shareable social media graphics. Please follow us on Facebook, Instagram, and Twitter. We're very active in social media. Please share our information. We have magnets for doctors' offices and students. One of our magnets is symptoms, and we like to see this little symptom magnet on dorm room refrigerators, because we feel that if you know, a roommate sees their roommate being sick, they might think they have a hangover, but they also might have meningococcal meningitis. So if they know the symptoms, they can act. It's all, again, it's about education. And we have videos. We just showed you our meningitis B in 90 seconds video. Next slide. So this slide ties it all together. And, you know, if there's nothing that you take from this conference or from our talk together, it's that we all have to work together in the vaccination space. And we know that there's a very small window to get the patient into the office and to get them from knowledge to action, and that's getting them vaccinated. So we need the individuals to feel that they're empowered to take control of their health, and we need them to understand the importance of vaccination. And we need to have communities that back them up. We need the providers to be having the critical conversations with their patients. We need schools, we need colleges, we need everyone in the community to understand and stand behind strong and clear vaccination policies. So all of us have a role in this to improve vaccination rates among adolescents. Next slide. How can you help us? Please help to ensure that no other young life is unnecessarily lost or affected by meningitis B. Learn more at our website, meningitisbactionproject.org. Please talk to your friends, family, community, your patients. Please tell them about meningitis B and the MenB vaccine, that there are two separate meningococcal vaccines. Please make it very clear. Please use our educational resources to help you educate your patients. Invite us to speak at local events. Alicia and I speak all over the country. Follow us on social media. Next slide. So, you know, while our main focus is on meningococcal disease, we'd be remiss during this pandemic if we didn't weigh in on the importance of the COVID-19 vaccine. So before we close, we want to share our latest initiative with you. It's called Families Against COVID-19. And we know that today we have the power to prevent COVID-19 with the COVID-19 vaccine. And that's why we've come together with other families and we made this video to share other stories of other vaccine preventable diseases, and people have lost people to other vaccine preventable diseases, to share one simple message, and it's don't take a chance, get the COVID-19 vaccine today. And here is our video.
I see your big smile.
When Kimberly got to the emergency room, one of the doctors pulled me aside and said, "We believe that your daughter has bacterial meningitis." That moment changed my life. The vaccine for meningitis B came available 2 years too late for my daughter.
Emily died from MenB. If there had been a meningitis B vaccine for Emily, in a heartbeat, I would have gotten it for her.
Trevor got sick with the swine flu. Had the strain of flu been put into the vaccine for that year, Trevor would still be alive. I would give my life 1,000 times just to have Trevor be able to live his.
I contracted polio in 1952. When I was in isolation, I was with a young boy who didn't make it. And I wonder what his life would have been. How quickly we forget. Vaccines absolutely save lives.
I lost my mom and my auntie to COVID-19. Every day there's somebody that's dying.
We couldn't protect our families, but you can protect yours from COVID-19.
My message is to see past the misinformation and receive the COVID-19 vaccination.
I can't wait till the day comes that I can hug somebody.
I've had my vaccine and I feel empowered.
Don't take a chance. Get the COVID-19 vaccine. Learn more at familiesagainstcovid19.org.
So at this time, we'd like to open up to any questions. If you have anything you think of afterwards, you can always contact us at info@meningitisbactionproject.org. Thank you so much for allowing us to share our stories and our work through the Meningitis B Action Project.
Thank you so much, both Miss Patti and Alicia. Your stories are extremely powerful. I applaud your courage, your diligence in doing your part to educate the rest of the community and making sure that, like you said, no other life is lost to something that is preventable by vaccines. Your work is powerful. Your work is needed. We appreciate you. We really do. Thank you for taking time to be with us here today so we can hear your stories. And so that we can share those stories with our patients and the families that we do have the privilege to serve. So again, I thank you both so much for the work you are doing and for us just being able to have an opportunity to partner with you all as well today. So again, as was stated, does anyone have any questions for either Miss Alicia or Miss Patti that they would like to ask while we have them with us?
Mika, there's two in the chat if you wanted to read those out.
Thank you. So one is a thank you. It says, thank you, Patti and Alicia, for having the courage to share your stories. Your message is impactful. Thank you for taking the time to educate all of us today. So absolutely, again, thank you for that. The question is, do you all have the last video in Spanish?
We do.
Perfect. And is it on your website that you gave us under the videos link?
I'm not sure if the Spanish, yeah, it should be. And if not, absolutely reach out to us, but we have absolutely had it translated into Spanish, yes.
Wonderful, thank you. And thank you, Miss Sandy, for your question. Is there anyone else that has any questions? Okay, and as Miss Patti said, if you do, please, you can reach out to either myself or Miss Dina afterwards, and we'll make sure to get those questions passed along to both of them so you can have your questions answered at a later time. Okay, perfect. And thank you, Sydney, for putting it in the chat, the link to the video in Spanish, so thank you for that. It was also asked, Miss Patti and Miss Alicia, if you all are able to share your contact information.
Sure, so it would be info@meningitisbactionproject.org.
And we'll try to get that typed into the chat.
I can type it in.
Oh, perfect, thank you.
Oh, there you go.
Sydney is on it. Thank you, Sydney.
Thank you.
All right, so that information is in the chat as well. Any other questions?
I'm just noticing, I don't know if that got out to everybody because some of it I think went to panelists, not panelists and attendees. So I'm gonna just make sure I'm kind of cutting and pasting here and making sure that gets to all the attendees as well.
Thank you, Ms. Dina.
So yeah, I think that's there, the Spanish one, and then also their email address. And as always, folks, just feel free to reach out to me. I can always connect you with folks if you don't keep track of it.
Perfect. Thank you so much, Ms. Dina. And also a thank you from Mr. Ray Bridgewater. He says, thank you for educating us and sharing your stories. So again, many, many thanks. So with that, we're going to transition over to some of our industry partners to further speak with us about the meningococcal disease. We're going to start with Dr. Hassan, who is the medical science liaison for Sanofi. And I'll just briefly read his bio before I hand it over to him. So Dr. Hassan is a medical science liaison at Sanofi Pasteur, U.S. Medical Affairs, and covers the Washington, D.C., Maryland, and Virginia. Dr. Hassan has extensive professional experience in the areas of vaccine and virus research and has published more than 50 research articles in peer-reviewed journals. He is a strong advocate and passionate about vaccines and believes that no one should suffer or die from vaccine-preventable disease. Sorry about that. Before joining Sanofi, Dr. Hassan was an active member of the CDC-funded New Vaccine Surveillance Network and was involved in vaccine effectiveness studies, mainly influenza and the rotavirus vaccine. Dr. Hassan obtained his PhD from Japan and postdoctoral fellowship from the National Institute of Health. So we are definitely in good hands with Dr. Hassan. So at this time, I will pass it over to him.
Thank you. Thank you so much. Thank you for such a nice introduction, and especially thank you my previous two speaker for sharing their story with us. It was a really heart reaching and appreciate. Dana, can you allow me to share my screen? I don't have in my iPad to share anything. Dana?
Yep, you should be on there to share. Hold on one second. Let me
I have two devices. One is the laptop, one is the iPad. I'd like to share from my iPad.
Okay, hold on one second. Hold on, Jackie.
Yeah.
Hold on one second and I'll get it for you. Sorry about that. Oh, that's why. I thought I got both. All right, there you go. Now the second one should be coming on. Let's see.
Yep. Okay.
Okay, there we go.
Okay, and give me a second, let me share. Okay, do you see my screen now? Anybody?
We can see it.
Yep, we can see you.
Okay. Thank you again. And today, thank you for inviting me here. My name is Firdaus Hassan, as Dr. Walker introduced me. I'm a medical science liaison at Sanofi Pasteur. So why we are here? Over the past 26 years, we have a good success against other infectious diseases such as measles and tetanus. But if you look at the meningitis, the reduction of global death only we have able to reduce by 21% versus 93% against measles. So we have long road to catch up in order to reduce this number of death globally. Now, I know meningococcal disease, my previous two speakers from Emily Foundation and Kimberly Coffey Foundation, they have described this disease and shared their personal stories with us. And actually there is nothing else I can share at this moment. But again, there are, so some of the slide I will really skip fast and some of the slide I will spend more time. There are, as they say, there are 5 serotypes, A, B, C, W, and Y. We don't see A in the US, it's mostly in sub-Saharan African country, but we see B, C, W, Y in the US as well as other country. Everybody can get a meningococcal disease. There is nobody is immune against this, but there are certain risk factors that put them in a more vulnerable group than the other, such as infant and teens and older adults, college campus. If you have certain medical condition like anatomic asplenia or HIV infection, or if you travel to sub-Saharan Africa, or if you are having sex with men or microbiologists or military recruits, these are all risk factors that put anyone in a vulnerable position. Not only that, also the mode of transmission is also really, really important in order to understand this disease, because it it transmits through droplet and respiratory secretion. And that is why our behavior, or the behavior from a teen or young adults, put them in a more vulnerable position, such as because some of the activities very common in this particular age group than the other age groups, such as kissing or sharing or eating utensils or water bottle, or even as a crowded setting such as college or household or military barracks or nightclubs or bars. The problem with this meningitis is up to 20% of us, like human beings, actually carry the bacteria. Although they never show symptom, we call them as a carriers. So even though they are carriers, even though they don't show the symptoms, but they can still transmit the disease or the bacteria to other people. And for this, this actually explained, and we are so sorry to see those two beautiful girls were taken away from your life. But those who survive, up to 20% of people will actually lose some of their. They have a more permanent sequel, the lose of their hands or limbs or other thing. So that is why it is really important that we spread the burden of this disease, not only to prevent death, but also to prevent this permanent damage that one can suffer throughout their life. And why this is so important, as they said, if you look at the timeline, the meningococcal infection and meningitis infection really doesn't give that much of time. And very early symptoms, first 8 hours, whatever we have, headache, sore throat, and fever, are really non-symptomatic, non-specific. So anybody can have this and not knowing they have meningococcal disease or infection. So by the time they know, or for example, at 17 hours, they have light sensitivity, abnormal skin color, and rash, that is more like they show that this disease is progressing, and it progresses within 24 hours. And by the time actually there is a proper diagnosis and go to a doctor's office, a proper diagnosis, there is not enough time to revive those patients from their coma or confusion. So that is why early diagnosis, although is important, but it is not always possible. So for this reason, the case fatality ratio is so high for meningococcal than any other disease. In the US, there are B, C, W, and Y, and this is past 30 years data almost. So it has changed, the proportion of B, C, W, and Y have changed a little bit, but it remained consistent. B, meningococcal B is almost 1/3 to half of this around meningococcal B. And if you look at the data, most of the meningococcal B disease are actually in young children. But as I said earlier, anybody at any time, at any given age can get any of this disease, although prevalence varies from age to age. Now, in 2015, the B was highest in 40, followed by C, Y, and W. If you look at the case fatality ratio, the W, the case fatality rate is 23.5%, highest among all the serogroups, followed by C, Y, and B. In the US, according to 2018 data, the case fatality ratio, overall case fatality ratio was 12% in the US. So because of this case fatality ratio, people really need to understand, as my previous speaker says, that the only way we can prevent this is through vaccination. And if you look at the age group, the most number of death, this is again from CDC data, National Vital Statistic Report, that has 1999 to 2012. If you look at the number of deaths, almost 400 deaths occurred between age 15 and 24. So this is more, although death occurs, every single life is important, though death occurs in young children and older people, but most number of children or death are actually 15 to 24. And also because of their behavior and mode of transmission, everything put this age group much more vulnerable than other age group. And because of these factors, this ACIP has recommended vaccines that are, as we know now, there are two types of vaccine. One types of vaccine protects against ACWY, and other types of vaccine protects against MenB. And the recommendation is the routine vaccine for MenACWY and shared decision making for MenB, as other speaker explained nicely. But if this is the vaccine coverage, if you look at this data, it talks about the people who received at least one dose of vaccine. And that number is actually pretty good, is 88.9 or 89% in the US between 2015 to 29. But when it comes to second dose, it is only 54% in 29. So people are getting the first dose, but they are not getting the second dose. And if you see, MenB is only 21%. So we have, although we are doing pretty good for first dose of MenACWY, we are not doing anything close to increase the second dose of vaccination. We are not doing enough to increase the MenB vaccination in the US. So what is the consequence? Even if you have 89% coverage, that means 11% people or kids are not, teens are not covered by the vaccine. So that actually represents at almost 1.8 million teens in the US. And for the second dose, another 1.9 million actually do not get their second dose. So combined, there are 4 million potential kids that actually walking around without vaccination, without protecting themselves and risking their life. So the next question is why we need a second dose of vaccine, because one dose, why not one dose is enough? There has been some study that was conducted by CDC, and it has shown that the antibody that actually protect the infection actually wanes after 3 to 5 years of primary vaccination. And another study shows by CDC, found that adolescents are not protected 5 years of the primary vaccination. And that is why a booster dose is recommended at age 16, because according to ACIP, the booster dose elicits a robust immune response, and data in adolescents demonstrate persistent for at least 4 years after booster dose. So when your kids are going to college at 16, if you give the second dose, they can be protected for their college life until 4 to 5 years. And this is the vaccine effectiveness study and duration and immunity. This is the data that CDC published. Now, they have shown the vaccine effectiveness for MenACWY conjugated with DT, and actually that is the only vaccine that has the effectiveness data and analyzed by the CDC. If you look at the vaccinated less than 1 year, the vaccine effectiveness is almost 79%. And actually decrease over the years from 79% at less than 1 year to 61% at less than 8 years. So that is why a second dose is important to boost those immunity and keep those people protected. Now, this is the recommendation. This is the mandate from 2019 data. As you can see, many of the mountain states and west, they do not, and some of the southern states, they do not require and mandate a meningitis ACWY vaccine for their schools. As well, many of the colleges actually do not also require meningitis ACWY vaccine, mostly in the mountain state, west, and some of the southern state. And my previous speaker was absolutely right. They do not, very few colleges and university actually require MenB vaccine, although MenB vaccine is very common in college campuses. Now, I'll take a 1 minute, and if you want to use your chat, please take this question. If a 16-year-old individual visits his primary care provider for a well check in October, what vaccines are recommended at this visit? There are 4 options. You can use the chat and write whether A, B, C, or D. A is the main ACWI second dose vaccine. The B is the main ACWI second dose plus flu because it is October, and talk about main B. C, flu A vaccine. D, main ACWI second dose plus flu vaccine. So if you use your chat box, please use and answer this question, whichever thing is the right answer. Okay, I'll give you another few seconds because of the time. All of you that responded B are absolutely right. Yes, you need a main ACWI second dose, you need a flu vaccine, and you do need to discuss main B vaccine with your patient. And not only that, you also check HPV vaccine if see they are up to date. You also check with their Tdap vaccine if they needed another Tdap vaccine. So these are all the vaccine that any healthcare provider need to check whether they're up to date or not. Now, no study goes or no talk goes without the vaccine coverage and how it impacted post-COVID-19. And this is a national claim data of main ACWI to show how the pandemic has impacted vaccination rate. This is the first dose, 11 to 12 years. Again, this is based on the claim data, IQVIA claim data. And if you look at the number ages 11 and 12, Maryland is down by 5%, DC is around 2%, not down, but a plus sign. But there are some other states which impacted, like Iowa is 16%. And this is the first dose. This is important to remember. But again, if you look at the second dose at 16 to 18 years, although the national number is down by 3%, but if you look at the DC, it is 26% down. Again, this is based on national claim data. And in Maryland, it is 5%. Virginia, there is no dose. So this is the time that we, as the college and universities are opening up slowly, it is the time to think about this meningitis vaccine and protect those kids, those students, and their families as well. With this, I think I am over my time, 15 minutes, and I'll stop there. And thank you for your time. If you need any information, please feel free to reach me out with my email, firdaus@hassan@sanofi.com. Thank you.
Perfect. Thank you so much, Dr. Hassan. Really briefly, for 2 minutes, does anyone have any questions that they would like to ask Dr. Hassan, specific to how the meningococcal disease pertains to the U.S.? Overall, we are going to look at it also next, specific to campus outbreaks as well. So if you want to hold your question to the end, that's fine too.
There's a question in the chat. Sandy asked, what's the recommendation for adults over 23 years of age?
So that is a very good question. Now, there is another speaker who is going to talk about more details about the ACIP recommendation. But again, these are all depends on the patient, whether he is traveling or he has some underlying medical condition or what is his profession. Everything depends on their situation. There is no blanket recommendation. It's based on their risk factors, travel, their medical condition, their health, and their profession. So I'm sure my other speaker will talk that in details.
Perfect. Thank you so much again, Dr. Hassan. So we're going to move into our next speaker. Perfect. Thank you. Okay, so the final session that we're going to have for today's webinar is very important. It's the recommendations from the Advisory Committee on Immunization Practices and the Immunization Action Coalition for meningococcal vaccines in children, adolescents, as well as adults. So today's speaker for this session will be Dr. Pilar Snowden. She is a vaccines medical science liaison with GlaxoSmithKline. She holds a bachelor's degree in biology and chemistry from Howard University, and she earned her PhD from Duke University, where her studies focus on humoral immunity and adjuvant science. She has been with GSK since 2015, where she has held both global and US medical affairs appointments. Prior to joining GSK, Dr. Snowden was a medical science liaison with Novartis Vaccines, where she served as the subject matter expert for its meningococcal portfolio. In her current role as a medical science liaison, she acts as both the clinical trial diversity and research lead for the vaccines MSL team. Dr. Snowden is passionate about making science and public health policy accessible and coherent in her community. So without further ado, I'll pass it over to Dr. Snowden.
Thank you, Dr. Walker. Let me know when you're able to see my screen, please.
It's there.
Okay, now I'm just trying to play the slideshow. All right, are we in full screen? All right. Well, thank you so much for having me today. I hope this presentation is a very practical overview of the current recommendations from both the ACIP and the Immunization Action Coalition for meningococcal vaccines in children, adolescents, and adults. As you can imagine, as we navigate returning to vaccination post-COVID, there will be considerations that have to be taken to ensure that we are following all of the guidelines that are currently recommended per the ACIP. So I want to begin discussing recommendations with speaking about co-administration of the COVID-19 vaccine with other vaccines. So recently, the ACIP has changed its language regarding co-administration. So previously, there was a recommendation to not co-administer the COVID-19 vaccine with other vaccines. That has now been lifted. And now the COVID-19 vaccines can be administered without regard to timing with other vaccines. Of course, as you are vaccinating, you want to take into consideration some things. Of course, one of the things of note is that if you are vaccinating with multiple vaccines at one visit, you want to make sure that you have separation at those injection sites. You want to be sure that you're following some of those best practices, labeling each syringe with the name and the dosage, making sure that you're taking note of the lot number, who has prepared the vaccine, making sure that you have separation at those injection sites. And if you are co-administering vaccines that may induce a local reactogenicity, so your tetanus, toxoid containing vaccines, your adjuvanted vaccines, if possible, place them in different limbs so that you can then be aware of those local reactogenicities and be able to ascribe them to one vaccine over the other. And so now I'm going to get into what the published recommendations are. Following this presentation, these slides will be made available to you for you to review. I do find that sometimes the CDC tables can be very overwhelming. And so what I wanted to show you here is a snapshot of what the current recommendations for the ACWY vaccines look like in those 18 and younger. So were you to visit the CDC website, this is what you would see. You'd see tables that speak about recommendations for ACWY. You have tables that review catch-up vaccination for children and adolescents. And then you have a table that looks at recommendations by medical indication. On the right-hand side, you can see a legend that basically orients you to the different types of recommendations. So yellow is the routine recommendation for ACWY, which is the first dose being administered at ages 11 to 12, and the second dose or the booster dose being administered at 16. That light green color indicates the range of the recommended ages for the catch-up immunization. And then the purple denotes the recommended ages for those who are at a certain high risk condition. I'm going to move to table 3 because this basically shows you if you have a patient with some of these medical conditions, pregnancy, being immunocompromised, having kidney failure, heart disease, that is not a contraindication to vaccination. So if you are 11 to 12 or 16 and you have some of these conditions, you should still routinely be receiving vaccination. There are some high-risk conditions whereby it is recommended that you receive the vaccine. Those are for your HIV infected patients with certain CD4 counts. And so that's the dotted yellow that you see there, as well as your patients that may have asplenia. So that can be functional asplenia, whereby their spleen does not work, but it's still present in the body, or if someone has had their spleen removed, they should receive the ACWY vaccine. Also those with complement component deficiencies. We also have recommendations for those who are above 19 or above 18, and that is based on risk factors. So the question was, you know, for MenB, I think it was asked, what do you do with patients that are above 23? We still have guidance for high risk indications. The next page gives a clearer view of what those scenarios are. And so the Immunization Action Coalition actually has a very handy, and I would suggest that you visit their webpage, a single page document that reviews all of the recommendations by age and risk factor. It also tells you, so we often, you know, we refer to things by brand name, but ACIP lets you know, because there aren't really preferential recommendations for the meningococcal vaccines, it lets you know exactly what the designation is for each product and how to vaccinate based off of that. So this shows you the routine recommendations and it breaks it down by age. So for example, if you have a preteen that's 11 through 12, you would give them their first dose of the 2-dose series at that age. And then it tells you that that second dose is recommended at 16 years. If you have a patient that comes in that didn't get their first dose at 11 through 12, but they're 13 through 15, you would give them the catch-up dose at that visit, that first dose, and then they'd be due the second dose at 16. If you have a patient that hasn't received, or if they've gotten that first dose, they're due their second dose at the 16-year visit. And then it gives you all of the possible catch-up ranges by age. So I think that this is a very handy guide that you can post in your office to tell you exactly how to administer the vaccine based on routine recommendation. It talks about those who are in their first year of college. So if you have a college student that comes on campus and they don't have history of prior vaccination, or they only received 1 dose when they were under 16, it gives you the guidance for how to vaccinate your patients so that they can be protected from the meningococcal ACWY. The one pager also gives you all stipulations for high risk recommendations. So the high risk categories are those who are traveling to countries where meningococcal disease is hyperendemic or epidemic. It's for those who are in an outbreak setting. So we just heard about outbreaks on college campuses. There are recommendations for individuals on those campuses during a time of outbreak, as well as those who are at increased risk for exposure, so your microbiologists. And then what I mentioned to you previously, if you have, if you're asplenic or you have complement component deficiency. So I think one of the things that we often forget with ACWY vaccination is that while the routine recommendation is for those 11 to receive their first dose at 11 to 12, and then the booster dose at 16, if you are asplenic, if you are complement component deficient, you should be receiving the vaccine as early as 2 months of age. And this table gives you all the caveats for that. So you have the first block tells you about those who are traveling, those who are in outbreaks. The next block tells you about recommendations for those with persistent complement component deficiencies. And the last block tells you the recommendations for those with HIV infection or those who have functional or anatomic asplenia. What you'll note here is that boosters are due depending on the age of the individual. While we know that if you remain at risk following your initial dose, your booster dose, if you are at a certain younger age, your first booster comes 3 years after the primary series, and then every 5 years thereafter. So you have to be well aware of what the booster dosing is. It is a lifetime booster in some cases for those who are complement component deficient, those who are asplenic. For example, if you have a college student who got their booster, they got their first dose at 11, they got their booster at 16, and now they're on college campus, they're 21 years old and there's an outbreak, they should be receiving a booster 5 years following the completion of the primary boost series. So there's stipulations here that you can look at. I know that I think our speakers did a great job of talking about shared clinical decision-making. What does that mean? It means you as an HCP, you as a member of the medical community are being empowered by the ACIP to ensure that you are making recommendations for your patients. You have the power to have conversations and to discuss risks versus benefits of the vaccine. This vaccine, when we talk about meningococcal B in particular, which is under that clinical decision-making recommendation, we know that vaccines for children covers vaccination for MenB for those 16 through 18 years of age, or those 10 through 18 who are at increased risk. So it's very important for you to discuss MenB vaccination with your patients. So this is what the MenB vaccination looks like per the CDC. Again, it tells you based off of color coding when patients should receive the vaccine. It also tells you by medical indication who should receive the vaccine. Again, the same applies for those 19 years and older. And I'm going to actually move to the Immunization Action Coalition view. Again, this is a one-page sheet that you can very easily put up in your practice. It discusses the 2 currently licensed vaccines for MenB. These vaccines are not interchangeable. If you begin a series with one brand, the goal is that you complete the series with that brand. If you do switch brands, you would have to start the series all over again. You cannot complete a series with, you cannot interchange these vaccines. So who should be vaccinated? At this point, you should be well aware of who those people are. Currently, the shared clinical decision-making recommendation is for you to have a discussion with patients 16 through 23. The preferred window for vaccination against meningococcal serogroup B is 16 to 18. And you see here the different dosing schedules for the two different products. So that's the shared clinical decision-making recommendation. We have risk-based recommendations as well. So if you have persons with complement component deficiencies who are anatomic or functionally asplenic, who are at prolonged risk because they are working with the bacteria, you can see what the primary series schedule is based on product, and it tells you what the booster dose recommendation is. So I know that I just spoke to the fact that the quadrivalent vaccine has a booster for routine administration every 5 years. It's different with the MenB vaccine. So if you are at continued risk for meningococcal B disease, the current booster guidelines is to give a booster 1 year after completion of primary series, and then a booster every 2 to 3 years later, as long as the risk continues. We can speak about the outbreak setting. So if you're 10 and above and you're at increased, and you're in an outbreak setting, the guideline is to, again, give that booster 1 year following the primary series. And depending on the nature of the outbreak, you may be due to receive a booster as early as 6 months after completion of the primary series. So the answer to that MenB question for those who are outside of that 23-year age range, it would depend on if you have some type of medical condition that there's a recommendation. If you're working with the meningococcal B bacteria, or if you are in an outbreak setting, if you're over 23, you would be due to receive vaccination. And so with that, I'd be happy to take questions. I do believe that some of the guidelines can be cumbersome, but I do think that having these one-pagers that give you clear cut instructions for how to dose based off of age and risk factor go a long way in helping you to understand your patients when they come in to see you and navigating those conversations about vaccination and why you should be vaccinated.
Perfect. Thank you so much, Dr. Snowden. And yes, thank you so much for, I like to call them cheat sheets. I love them. They make it so much easier. So I definitely will be printing these down and adding them to our vaccination room as well. So thank you so much for sharing that. Are there any other questions for Dr. Snowden in regards to the recommendations? Any questions? You definitely visually help make it easier for us. So thank you, Dr. Snowden.
You're welcome.
For that. Perfect. All right, wonderful. Well, again, thank you to all of the speakers today for your time, for sharing your knowledge, your insight, and definitely the information for all of us that are here on the calls that we can implement them in our practices. Again, as I was saying in the newsletter that went out yesterday, the reason that we're having these webinars is so that we can make sure that we're equipped with all the tools that we need so that we can really do our part to help advocate for these vaccine preventable diseases, especially since we have seen such a decline with the pandemic. So as stated also at the beginning of the webinar, we will have more of these sessions. So please, if you all have any topics that you would like for us to cover, please let myself know, please let Ms. Dina know. so that we can definitely do our part to make sure that we are providing the information so that we all feel like we have the necessary tools to really hopefully see a rise in these vaccination rates once again. I know that we can do it, but it's definitely going to take a team effort. So I'm really happy to see, representation from a lot of different organizations, from, like I said, pharmacists to nurses, doctors, other healthcare professionals, and community leaders. It's going to take a collaborative effort from all of us to be able to really get this job done. So I hope that everyone enjoyed this webinar. I hope it was advantageous for everyone. I hope that you were able to gain some information that you will not just hear, but again, the most important thing is really putting it into practice. So I thank again all of the dynamic speakers. Without you guys, we would not have been able to have this webinar. I really appreciate you all for your time. Ms. Dina, did you have anything that you wanted to add for those attendees that are on the call today?
No, nothing to add. Just thank you so much to everyone for participating, and just two things in the chat that folks are just saying thanks for such great and useful speakers, and thanks to all the panelists. So I think we all really appreciate that, and we will follow up with this to just figure out what's the best way to, if folks have been asking me about whether we were going to have it recorded, would it be available? So we just need to explore that a little bit about whether we'll put it on the website or just make it available, and also speaker slides. But so we'll be back in touch with everybody soon, just if there's any way that they want to get to this information. So thank you to everyone again. And as you exit, please take the survey. It's very short, but it really helps us to inform what we do with future sessions. So we really appreciate your input.
Wonderful. Thank you, Ms. Dina. And thank you all again for your time, for joining us this afternoon. I hope everyone has a wonderful rest of your day. Continue to stay safe and stay well. And we will see you all next time. Thank you.